recording this session so that it will become available later on demand at the STN website along with the other webinars that the Marketing Committee's been hosting. Your lines are muted, so we cannot hear you. However, if you have questions as we go along, you should see a questions box on your GoToWebinar control panel. If you have questions, Carol and Dr. Jenkins are going to try to take some breaks throughout the presentation to answer some questions, so go ahead and type those in as they come to you, and then hopefully we'll have some more time at the end to answer any further questions. For CME for this session, you will be receiving an email with a link to take an evaluation in the next 24 hours at the conclusion of the event. Once you complete that evaluation, you've completed the process, and you should be emailed a certificate in 5 to 10 business days. If you have any questions, feel free to contact STN headquarters at the close of the webinar. I am very proud to introduce to you two of STN's hugest supporters. Dr. Donald Jenkins and Carol Immermann are a team from Mayo Clinic in Rochester, Minnesota.
Well, good afternoon to the East Coast and Central Zone people, and good morning to the people on the West Coast, and anybody who's warm, I am jealous. So thank you for joining us, and just a few things we'll talk about here as we get ready to talk about the taxonomy. The objectives of the course here, you can see we are going to talk about the steps undertaken getting the taxonomy. If you want to start doing this in your PI program, we'll be talking about some ways to get started. We'll be sharing some of the tools that we're using and that we know are coming available to you in the near future. I think the biggest thing with all this, and Dr. Jenkins will be discussing this at length, you know, why are we doing this? Why this new taxonomy? And so we'll give you some history and say, show about this introduction of this culture of safety and the language that it's using, and that it really will, we see it complementing and really enhancing the trauma PI process as we're doing already. We are required to say that we have no conflict of interest. We're not making any money out of this, and Kim hasn't slid us anything under the table for it. Continuing Education, Society of Trauma Nurses will be providing contact hours, and again, as Kim said, once you fill out your evaluation, you can get 1 contact hour. If you're watching this on afterwards recorded, there'll be some questions. You'll be able to watch this, answer a few questions. Then you'll get CME, or Continuing Education, not CME, sorry, and that will expire on February 28th. So you have just a couple days to get that done. And again, to do this, you have to listen to the whole event. Here's the test. You'll be able to see that when you're reading it. So to get started, what would help us? We're going to have a few pollings throughout our talk. When you see that vote button, that's going to be one of your opportunities to participate. So if you could help Dr. Jenkins and I, let us know who is on the phone. Trauma medical directors, program coordinators, director manager, PI coordinators, registrars, and if there's an other, just take a few minutes if you would, and let us know who's on the phone, please.
Okay, it looks like people are voting now. We've got about 90% voted, so we'll give you just a couple more seconds and we'll launch the results. Okay, so it looks like our results. Carol, can you see those?
I can't.
Okay, so it looks like 60% of our attendees are trauma program managers, directors, or coordinators. We have 17% PI coordinators, 5% of them are registrars, 2% are trauma medical directors, and we have about 15 that fall in the other category.
Okay, excellent, excellent. So a nice variety of people joining us. Now we're really curious. You know, I'm happy to share when Dr. Jenkins first came to me with this taxonomy thing. I could have said all of the above and added more, but I'm just curious what you all think when you hear the word taxonomy. You think, you know, I am going to have to, the way that I've done PI up until now is going to completely change. Everything is completely different, and I'm going to have to come up, this is all brand new. Well, maybe it's okay because there's patient safety, culture safety terms with it, so maybe it'll be okay. There goes the ACS messing with us again, or anything that has the word tax in it can't be good. We'll give you some time to vote on that.
Okay, it looks like we have about 90% participated, so I'll give you about 3 or 4 more seconds. Okay. And it looks like 70% of our audience thinks it will be okay. 18% of them think they're going to have to change everything. 6% feel like ACS is messing with them, and 7% think it has the word tax in it, so it can't be good.
Okay. Well, good. I'm glad to hear that you're thinking that hopefully it will be okay, and hopefully you'll feel even better about it at the end of this talk, and we'll give you a chance to share that again. So, you know, just first of all, starting with this, you know, why do we need to change? And that's what we're going to address it now, and I think this is a nice quote from the Forbes website. Change is difficult, but not changing can be fatal. And we've seen throughout history with healthcare and some of the ways we've done things in the past might not have been the same. So Dr. Jenkins now is going to be talking about the culture, safety, and again, why we are changing.
Well, thank you, Carol, for the opportunity to participate today. For those of you that may not know this, I am also an STN member. We have been working now with American College of Surgeons Committee on Trauma, Performance Improvement, Patient Safety group, starting with Glenn Tinkoff and then Blaine Anderson, and now me with the STN to come up with a new version of the topic course. And the charge came to us from the leadership of the Committee on Trauma that we were no longer going to be able to continue to do things the old way. This cartoon sort of represents and the way I was raised up as a trauma resident, as a resident of general surgery, that when something bad happened to a patient, it was your fault and your fault alone. And the choices that were given to you was that the reason this happened is because you were lazy or stupid, and sometimes both. That's an old school way of thinking about things. Maybe there was a merit to that at some point in the past, but today that doesn't hold. The way that we have gone about healthcare problems and issues in the past has really resulted in people wanting to direct attention away from themselves. That if they were in some way affiliated with an event where maybe a wrong medication or a wrong dose of medication was given to a patient, and our approach to that is to punish an individual when in fact there are system issues afoot where maybe medications are stored alphabetically perhaps instead of by their action, that you could see how you might end up making mistakes like that because the system allowed it to happen. And this is what happened to the aviation industry, and it was after a couple of bad crashes that they realized that they had some problems. They needed to flatten the hierarchy. They had to hold everyone not only equally accountable, but also and expect that everyone could raise their voice in concern. And they have truly turned things around. You know, the plane doesn't take off if every green light doesn't come on. They will go through the checklist, and if something's not right, next thing you know, an engineer's on board and fixing something. And they don't make any bones about it. It's if the flight doesn't go on time, they're not going to bow to the corporate pressure for that. They are going to do the right thing, and do the right thing, you know, every time. And to have that culture of safety now take over inside of our hospitals is a new way of doing things, and that is not lost on any of us. We go to the next slide. So that culture of safety. Sorry, I think we need to go back one. Culture of safety. There's just absolutely no room for finger pointing. In fact, in our trauma center, when I took over as the trauma medical director, I abolished M&M. We do not have a morbidity and mortality conference. What we have is a performance improvement for providers seminar. And what we accept up front is that something bad happened to a patient. And while we will want to know if maybe there were some individuals who had something to do with this who might need some additional education or training, really what we're looking for, and it happens in many, many instances, are system-related issues. We're going to accept that the problem happened, and our focus is going to be on what we can do to prevent this. So no finger pointing, no more lazy and stupid are my excuses for why this thing happened, because we want to get to the root of the problem and solve it. People don't go out and you know, make mistakes in the care rendered because they're lazy or stupid. Everyone wants to do a very good job, but sometimes things conspire against us. And as we move forward in this culture of safety and put our performance improvement process through it, it would be a really good idea if we could catalog events and contributing factors in a way we haven't done before. Now, this is where we go to the next slide, and you can see that there are national organizations that have come forward to help us do this in the healthcare environment. And that last group that I identified there, the Joint Commission, this is where the American College of Surgeons got involved in some discussions with member organizations, if you will. Centers that are level 1 trauma centers verified by the American College of Surgeons, who, when they were visited and it was found that their performance improvement programs were not up to standard per the reviewers, hospital CEOs got their attention focused on this and felt that the review process was not only very subjective, but a completely separate process than the rest of the hospital quality actions and organizational structure. It took them by complete surprise. How could they have such good scores in so many areas in national quality forums and then fail their site visit because their performance improvement program wasn't good enough? It was mystifying to many why they had an entire suite filled with people that do nothing but quality, yet over there in that trauma center, they've got 1 or 2 people who are rogue agents. They don't do things, they don't use the same language that the rest of the hospital uses. They have different definitions for a urinary tract infection than the rest of the hospital, or ventilator-associated pneumonia. And who is this American College of Surgeons Committee on Trauma to upset our apple cart, if you will, in that way? And so the including the Health Care Facilities Accreditation program. And so it was at this juncture that the Board of Regents heard this loud and clear and went to then Chairman Mike Rotundo of the Committee on Trauma and said, you guys really need to get on board with what else the hospitals are doing. And so that's where this National Quality Forum language sort of came into being, and anybody who's taken a topic course in the past 2 years has been introduced to it. And now a group of us has been charged with, if you will, traumafying it. If you go to the next slide, you'll see that the pioneer in this, Nancy Martin and Rao Ivaturi, published this article in terms of what they were calling the maximum impact management errors at a level 1 trauma center, and showed that in fact one could catalog errors, issues identified using this National Quality Forum language. If you look at the next slide, this is the core document from which we have taken much of what will become the core of our language that we use for cataloging trauma-related issues or issues that come up in trauma patients in our trauma centers. And so both of these references are very good references to go through. There's one more, and I'm sure that Carol can make this available to us, which is a study that was just recently published by the guys at Penn. And what they did was, using the National Quality Forum language, went into their trauma center, looked back at their deaths, and ran their deaths through using the new taxonomy. They also looked at their action plans and for this, and to paraphrase what was in that paper, they identified that the majority of the issues that arose that were related to deaths arose in the emergency department, and that the majority of those events involved communication problems, communication issues. Their number one action plan, based upon what they thought was going on, was education. And not certain that that's the right action plan where communication is concerned. Better opportunity, avenues for communication, maybe some education about communication, but in essence, they had come up with a plan to solve these problems that wasn't really on the mark because they had not been cataloging those issues in that way. This graphic that you're looking at here from the World Health Organization, this is your Trauma Performance Improvement Program roadmap. It starts with that triangle in the middle where something happens to the patient. And when we see that something has happened to the patient, we look a little bit further into it. And those ovals on either side, the patient brings something to the game, but there are incidents or characteristics of the incident as well. If you have an isolated trauma patient and there is a delay to performing some critical measure, versus if you have 6 simultaneous and equally injured patients, one could see how a delay in a critical element of in the care of one of those patients could be explained in the incident characteristics there. If the patient is 800 years old and on warfarin with an INR of 14, well, they bring something to the table as well for that. There are other contributing factors, as you can see in the oval above that. And as you go through this map, it's one good. I think it's a poster you hang on the wall in the room where you make trauma rounds, and this explains what we're going to cover in the next several slides. So if we look at the patient safety taxonomy, there are 5 primary classifications, and these are impact, type, domain, cause, And then what is termed in Joint Commission or the National Quality Forum lingo as prevention and mitigation, which we might call action plan and loop closure. So the impact is a degree of harm. Something happens and it results in some degree of harm. So there was a missed page, the neurosurgeon didn't show up in the trauma bay to examine the patient, and there was a delay, but the patient did fine and there was no harm. Well, that's still something went wrong. We were expecting the pager system to work or the neurosurgeon to show up, and even though the patient didn't have a harmful outcome from it, it is still worthy of uncovering what went wrong so that it doesn't happen again. And that level of harm goes all the way up to Roman numeral 9, the ultimate harm, which is the death of the patient. Now the type comes down to processes that were faulty or that failed. And this can be associated with diagnosis or the treatment of the patient, equipment-related issues, communication issues, etc. Now the domain shows the characteristics. This is somewhat like the who, what, when, where, how, if you will. And it is interesting when you look at these communication issues. For instance, in that pen paper, it was resident communication issues that seemed to rise to the top, as I recall reading that paper. Perhaps someone will correct me if I'm wrong in that. But this is important to understand where these things are happening and potentially, how often those things are happening. So that if the majority of your communication issues seem to be coming from one area, then that should become a focus of what you intend to fix. Next major classification, heading the cause, and these are factors that help to lead into this event. And then, as we said, the prevention and mitigation is the action plan and loop closure. So in December of 2013, Chris Kribari wrote this note that essentially the National Quality Forum taxonomy has been recommended by the COT PIPS committee and the Verification Review Committee as excuse me, best practice, and it should be implemented. It should be implemented now because it will become a required criterion in the next version of the resources for the optimal care of the injured. And I assure you that we are working on that now. This is a process that we're going through with a small work group. The PIPS committee will be meeting next month to review this in some detail. As written, the National Quality Forum language and definitions leaves something to be desired for trauma-related issues, and so we are working on the traumification of the language, standardizing some of the definitions and even providing some case examples of what we mean, because when you look at the impact on a patient, if there's a physical impact that's deemed severe temporary harm, how does one differentiate moderate temporary harm from severe temporary harm from severe permanent harm? And this is where the group is getting together to make these definitions, because our hope is that in the not too distant future, this will become a part of TQIP, where TQIP will not only be able to benchmark your patient outcomes, they will help you to benchmark your own performance improvement program and ideally make it so that your performance improvement program is beyond subjectivity. That if someone comes in and says, well, wait a minute, you should not have made this incident a minimal harm, you would be able to go to your definition in your PI plan and show them, in fact, it is exactly a minimal harm type of event, and that in your PI plan, you may have decided that if there is minimal harm or lower, that those issues can be handled at the primary review level and don't even need to go to secondary level of review. If that's in your PI plan, then that's how you make that work. There are some places that are going to take every single event all the way through, tertiary level of review. We think that that is unnecessary in many instances, but my goodness, if you have the people and the time to do that, that would be the ideal trauma program. And so I think you can start to see that if we were to codify this, these definitions in this language, that now all of a sudden where TQIP has you enter acute kidney injury, and it's a one-size-fits-all process, there's a vast array of different types of acute kidney injury and the impact on the patient. And so that if you have acute kidney injury as defined and the creatinine goes up and it comes right back down, fantastic. If the patient leaves the hospital with a brand new dialysis shunt and a lifelong dialysis, that's a far different outcome for that patient. And today, we just are not able to capture that sufficiently. And that's where we are going to get so much better at classifying the events and the contributing factors and such in our trauma centers. If you look at the next slide, so just something as simple as what is a missed injury or a delayed diagnosis. This is something that when the site reviewers come to your site, if there's 3 of them, that means that there are probably 4 different definitions for each one of these, your definition and each of theirs. And we think that it's time that we put this to rest and decide on one good way of classifying something as simple as a missed injury or a delayed diagnosis with a standard definition that can help us to move forward in terms of then being able to tabulate these events and be able to benchmark them one against another. There were Carol and Jory Klein and Amy Kestner, I think, did a little survey on this. They came up with at least 15 different definitions of each of these 2 items alone from trauma programs across the country. And that's just not going to fly.
Dr.
So
Jenkins?
I'm going to.
Okay,
Yep. Go ahead, Carol.
Yeah, thank you so much for. You always explain this so well, and even though I work side by side with you, even listening, I still always learn more. So this is a time to pause. He's telling, here's the history, here's the why, this is how it would be used with trauma. Kim, I don't know if you've had any people ask questions or if somebody has typed anything in yet.
Yeah, I don't have any questions to this point.
Okay. So please feel free. I'm assuming, again, do people know? You just type it in on the screen to make sure that I hope everybody can see where it is to put your questions in, and we'll answer them. And the next slide, what we're going to do, this has to, so again, what Dr. Jenkins was talking about with, okay, we have these complications, and here's some ways that we can really drill down and decide the true level of harm to the patient, but capturing this. So how do we do all this? You know, you can look at that international classification poster from the World Health Organization, and it looks great, but how does this all work? So I'm curious, here's another vote slide. So Dr. Jenkins talked about an event with neurosurgery not responding. I would ask, you are wondering how many, so you have a problem with, let's say your trauma surgeons are not showing up to the trauma bay as often as they should. You know, you're not reaching the 80% threshold. And so you're wondering, did shift change have anything to do with that? So if you're trying to run that report or figure that out in your current system, how would you do that? A is you would review PI reviews in your registry database. B, you'd run a report on these very specific data points out of your registry database. C, you'd have to review minutes from PI meetings. D, you do not have the ability currently to be able to run a report on that. So if you'd please vote on that.
Okay, it looks like people are voting right now, and we did have a few questions come in. So as soon as we get these results reported, we'll take a break to start answering some of their questions. It looks like several of them have to do with the Orange Book. So it looks like we've got about 85% of participants voted, so I'll give you about 5 more seconds if you want to participate. Okay, and I'm going to share those results right now. It looks like 82% will run a report on the data points in their registry. 9% will review them, review PI reviews in their registry. 6% said they cannot run this report in their current state, and 3% said they would review their minutes.
Okay. So Kim, I'm going to go to the next slide that kind of complements this, and then we'll get the questions if we will. So I can tell you in the current state right now out of my registry, I can see maybe time of day and different things, but again, I have shift change differences too. So I have to, was this an 8 a.m. shift change time? Was this a 7 a.m.? Was this a 5 p.m.? There's not really a specific filter for shift change. And so here's the taxonomy tool, and here's what we would see some of the benefits of it. So this is something that you can, this is the paper form, if you will, and you would see that in the domain, we talked about, this is giving you an idea of where things happened. So it happened in the emergency department. It was the trauma consultant was involved, and it actually happened at shift change. This tool is part of a trauma event tracking form. This is something that we use during the topic course. This is what we use when my PI coordinator is in rounds. This is something that is available and can check things off when we're doing real time. But again, there's tools to be able to capture that. And then the software, I did want to let you know that I'm aware of 2 software companies that have this available. I'm not aware of all of them. But this, we use trauma-based, and this just shows you how impact type domain system, how that would be up at the top, and then there's drop-downs with that. So it'd actually be able to say in the domain, trauma surgeon, shift change, and then would be able to run the report out of the registry with that specific audit filter. So if you want to go ahead and do those questions, Kim?
Sorry. Several of the questions are on the Orange Book. One of our listeners asked if it is effective with the Orange Book or in the near future. I guess
I would be happy to answer that question. We can only hold trauma centers accountable for what is in the Orange Book at the time of their site visit. What is new to the Orange Book, which would be ancient history to probably most of the people on this webinar, is the introduction for the first time of the concept of primary, secondary, tertiary level of review, and the words action plan and loop closure. So just as those concepts were promulgated through the topic course and constituted the poster on the American College of Surgeons website in the Green Book era, that poster then became the subject matter for the Orange Book. What we are presenting to you here today will be in poster format on the American College of Surgeons website by this summer, about the time that the Orange Book takes effect. And the next iteration of the book will make this the requirement. So for those that believe that, well, if it's not required in the Orange Book, then I'm not going to worry about it now, you'll have a pretty steep hill to climb because in less than 2 years, we anticipate that this section, Chapter 16, will be updated with this new material. In the words of the Verification Review Committee and the COT chair, the days of updating the entire book all at once are over. That they intend to change sections and or chapters as new material comes on board. There will be a life cycle of that chapter and the process by which it works its way through to finalization. And they anticipate something on the order of 18 to 24 months of time, review, etc., to go ahead and make those changes and then put them out there for use. So I think what you'll see is that somewhere between 2 and 4 years from now, this will be the way that PI will be required to be done. We believe also that there is strong potential that by the end of the calendar year, early adopting centers will be able to submit their PI-related data to TQIP. Now, that's a bit ambitious, but we are working on this. There is an hour-long phone call every other week with a group of about 8 people that are NTDB, TQIP, VRC, and PIPS, all working together to bring this to fruition as quickly as possible.
And then just to add to that, Dr. Jenkins, on page 117 in the Orange Book, it does talk about trauma centers should promote a culture of safety, patient safety, that acknowledges multidisciplinary aspect of trauma centers. Again, getting away from applying blame, and also referring to National Quality Forum, Institute of Medicine, and Joint Commission, which is, again, those groups are using this taxonomy. So it's the concepts are, the ground is being laid for it, and then it just was really understood that there needs to be some more traumification of all of this as it would. So,
Carol, I think one more quote probably out of that chapter is something to the effect that the trauma program must demonstrate the linkage between the trauma center PI process and the overall hospital quality program. Is that accurate?
That is accurate, yes. So I think we'll move on just for the sake of time, and but again, please keep putting your questions in. I looked at this picture and I thought, this is what it's like being on a phone call. I don't know if you're happy, depressed, angry, what you think about all this, but I just to pause and review this benefits. Just again, this first bullet point talks exactly what Dr. Jenkins just said, where this will give you the integration of trauma performance improvement into your institutional performance improvement. I can share that at our hospital, we were having issues with, we have an ER and some way that you put orders in there, and anyway, it was a process there was a process that was delaying how orders were being entered on patients who were admitted. What we found out that these were all being called into an event line and it was all being looked at, but nothing had reached a severe level of harm. There was no harm to a patient because people were all doing workarounds. Now, before I was using this taxonomy, I mean, you could say, well, Carol, you should understand what a level of harm is. Well, yes. But now, again, with this common language, knowing institutionally they're using the 1 through 9 impact, that they are deciding what level a number needs to get to before a root cause is done. I might say in my trauma program, I'm going to use that same language, but in a situation like this, there's so many times it's happening that I'm going to do root causes and try to do some fixing just because of the number of occurrences. But I feel like I'm, again, speaking the same language now, where before it was separated. Again, I think hopefully that you see this as a more sophisticated classification system. You'll be able to drill down and focus your action plans. As Dr. Jenkins had shared, the Penn article showed that action plans were being done. It was more of an education type thing, where when they drilled down and saw that the root cause was really communication, okay, maybe communication has an action plan of education, but the education might not be, assessing a patient. It's communication with team training, or again, maybe it's having more phones available, or things like that. It gives you the ability to really, really look under microscope at what the issues might be. And then again, the ability to be able to pull these specifics right out of the registry, I think, will be very helpful. Now, a lot of times when, and I'll confess, the first time I looked at this and I looked at all these categories, it's like, oh my gosh. So the first thing you might want to say is, okay, do I need to do all of these? There's all of these drop-downs. There's all of these categories. What do I have to do? And just again, as we shared earlier, are we going to do everything on all events? Do you complete all the categories on level of harm? Do you create an action plan for every event that is done? And this again, what we're thinking most people are going to do is that they'll be completing the categories based on the level of harm. So what we are doing, and again at Parkland they're doing this, at Jory's facility they're drilling down quite a bit more, but again, a lot of this has to do with the resources and what you have. But every event really should include a level of harm. What was the impact to the patient? Again, I think the example Dr. Jenkins gave with the acute renal injury, acute kidney injury, what was the impact to the patient? And certainly any event that caused patient harm should have further investigation. And then with the example that I just gave, consider looking at events that are happening frequently. Those certainly can be near misses. And just because they haven't caused harm, if it keeps happening over and over again, it certainly could cause harm at some point. So at a minimum, assign a level of harm. And again, these definitions should be soon. And then once you get this, what do you do with all of this? Well, again, you can get, what this really is getting into a root cause analysis of where it happened, who was involved, time when it happened. We also look at the, what phase of the patient's care. Was it resuscitation? Was it post-resuscitation? Did it happen in the rehabilitation phase? There's ways to really be able to drill down, and when you do your annual review of your PIPS program, you can look for trends, and then that can help trigger what you want to do forming your plan for the next year. We did change the wording of track and trend. We always say not to do that. So again, if you have an action plan of tracking trend, the word we want you to use now is periodic reporting. So shift change, how often these things are happening, who is involved. Again, this will be something maybe you decide that it'll be quarterly at your PI committee. Maybe with system issues that it comes to your multidisciplinary operations committee. And certainly, again, we think that this will help you develop action plans more specific to exactly what the problem is.
Carol, if I could interject one comment here, going back to something you had said just a few moments ago about your program interfacing with the hospital. And the excellent example that you gave, that in fact many other areas in the hospital were identifying the same problem, and that this is the benefit, the beauty of being able to interface with the entire hospital, is that others may have experienced this. They have maybe already come up with a solution for it, and that by being a better partner in the bigger picture within your hospital only stands to benefit your patients.
Thanks, Dr. Jenkins. So you have touched a little bit on where this is going in the future and in the near future. So anybody who's ever worked with Dr. Jenkins, when he talks about wanting something of the year, we always joke that when do you want something, and it was yesterday. So we are hoping to be having some of these things quickly. Certainly there needs to be a trauma dictionary to define all these terms for the taxonomy, and hopefully you see that we have started that. We know that, again, for these levels of harm, temporary, permanent, whatever, what does that mean? So we will, along with your NTDB data dictionary that has the definitions for the MI and acute kidney injuries and those things, so also be a dictionary for the taxonomy elements. As far as incorporation of the taxonomy into the trauma software programs, again, I do know of two systems. I know those of you who use Collector and those of you that use trauma-based, DI and CDM, have those, the ability to have that in. I know that others will be looking at that. So again, we are not asking you to completely change this. I'm not asking you. The ACS is not asking you. This is not going to change how you're doing PI. You are still going to identify events. An event comes up. You will still do a primary review to validate if this is really an issue or not. If there's needed, you will still take something to a secondary level review with your trauma medical director. If need be, it will go to tertiary review for multidisciplinary review. And if need be, some of the facilities might also send on to quaternary review to have others to help with that review. None of that is changing. But what we're saying is if you have something that's a big issue, perhaps part of that, once the level of harm is given, then you can start filling in the where, when, how, who is involved. It would be something that I could give a summary right out of the registry and send on to my PI medical director and say, here's this event, here's the issues and things that happened around it, and it can be an attachment on an email that has this all summarized very nicely. Then during the site review, again, we can pull out these same summaries that shows what's going on, and if you have exactly what it is, a very specific action plan that addresses that certain event. Dr. Jenkins mentioned about the PIPS poster that will be coming hopefully in June. We really are hoping, our goal, the plan, is that there will be benchmarking of PI. We've had some hospitals that have been TQIP, early TQIP adopters that are familiar with this and have volunteered to use this taxonomy and try it out. We come, with this group, multidisciplinary group comes up with definitions, it goes in their software, and they start using some PI, and how can this be used, again, not only in individual centers, but for benchmarking, and then ultimately during site visits. And as was mentioned earlier, you submit your PRQ for a site visit coming up, and in your data fields, you not only have how many penetrating and blunt and ages and finance and all those things we put in our PRQ, but how many of our issues, PI issues, had this level of harm. You can show trending with that, how that's incorporated into your PIP. So, and again, think of that with the site reviewers with PI, how much, what value that will bring for future site visits. So there's a lot that might sound like there's a lot to go with it. So how do you get started? First of all, I would say you can contact your registry vendor and see if they have that taxonomy, if you have the ability to use that. What we did is we took a topic course, and we're fortunate that Dr. Jenkins and I both teach it. So, but through that, we learned more about it. We did a literature search, and we did, again, we have education with your registry. This was an agenda item on our topic committee, and went there and explained to everybody there that this is what we'll be doing in the future. Obviously, the PIPS committee, we did the same, and everybody, all the program staff. So it starts with education. I know when Jory at Parkland, when they started, she said, we're just going to do it, and they jumped in both feet and had all the categories and said they were going to look at everything. we've taken a little slower approach, and it's cold here in Minnesota. It slows us down, you know. So we just concentrated on our desks and just, again, to be comfortable and to get a little more comfortable with the terminology. Again, having this new language will really be the icing on the cake. This is what we really need to really make this to go forward.
And we do intend to use the degree of harm as cutoff points for what issues can stay with Carol, what issues that I can decide upon, and those issues which must go to the full committee. That'll be in our performance improvement plan, and a site reviewer may take issue with a particular case, but if it falls within the realm of being reasonable, then that's what that's what we'll go with. One more thing I think that needs to be mentioned is that Blaine Anderson's intent is by the 1st of July is to put together what he feels is the ideal performance improvement plan and program. Not that you couldn't vary from it by, like I say, a degree or two, but all of these things would be laid out in such a plan that you could use as a template. Imagine if performance improvement were done in all the trauma centers in this country in a very like fashion, how we could move the needle on some of the issues we face. That's the ultimate goal.
So Kim, I've got about 12:54. I think this, I was going to have people do this last poll at the very end of the webinar, so I think this might be a good time again to ask some questions, open things up for questions.
Okay. I think you answered a lot of the questions about the Orange Book already, so if I ask a question that was already answered, feel free to let me know. One of the questions was that the Orange Book states you must use a classification system. Are you suggesting that we must use it?
So it's currently not saying you must use it, but it will be coming. So again, to meet the letter of the law for the Orange Book, if you are having something July 1st, they're not going to be, the reviewers cannot be looking for this classification system. We think that there's great benefit, though, in starting now because it is coming in the future.
Okay. Yeah, and what is developed will be what is in TQIP. And so if you're a TQIP participating center and want to have your performance improvement program benchmarked with the other centers, just as your outcomes and complications and such currently are, then you would need to adopt the standard language.
Okay, and the next two questions are from two different people, but I think they kind of go together. One question is, can it be used if you don't have TQIP, and when can we expect the trauma definitions to be published?
The answer to part one, yes. You do not have to be a TQIP participating center to use this. Second question is that is up to the work group to put this together. So Dr. Anderson sent out last Thursday or Friday a draft of what he would like to present to the PIPS committee. If approved by the PIPS committee, then that would go to the executive committee for approval, which would be the early version of this, if you will. We are working closely with the NTDB team. Where a national quality forum definition exists and NTDB doesn't have one, we likely will take their version of that definition. And it is a painstaking process. When it would become available sort of in TQIP that's $1 million question. It could take them 3 years to build this such that it could be electronically reported by the time they get done with all the definitions, etc. We think we can have a good working document with trauma-fied definitions, like I say, by the time the Orange Book takes effect this summer.
Okay. And the next couple of questions are about implementation and timing. One is, with the site survey, we have 18 to 24 months of data collected. If we are transitioning a taxonomy, how would that affect us as a site visit?
So that's a question that we have asked. We've asked that question about a lot of things that are in the Orange Book, and what we have been told is that, well, of course there's going to be some transition, and that there's some expectation of that there would be some perhaps allowance for that. But it is the American College of Surgeons we're dealing with. The book is printed in black and white. So, yeah, that's why I think people should be adopting earlier rather than later.
And just to fill in with that, we're in the midst of a site review period as well. I'm not going back to 3 years. We had our last site visit in 2012. I'm not going back to 2013 and adding all these taxonomy things in. Again, first of all, without having exact definitions, we can't put that in, but we're able, at least again with the levels of harm and whatever. So our plan is to be having this taxonomy with our site review coming up. We want to show the reviewers. We're hoping we can show them a product that will be helpful to them. But going back for the 18 to 24 months, if that's what you're asking, do you have to go back to the 3-year period? I would say no. And Dr. Jenkins, you do a site visit. You're a site reviewer.
I agree with that.
Okay.
We have several questions about some of the tools that you have shown today. Carol, is there any reason that we can't post any of those tools, like the tracking form and the poster on the STN community for people to begin using?
Absolutely not. I do want to let people know that this form is one that's been, so the categories, the impact, the domain, whatever, those are correct. It is pretty much set up for a level 1 trauma center with lots of specialties. So it can be, feel free to modify it. You do not have to have, you don't have spine people at your center. You don't have to have spine on this. Again, so you should feel free to be able to modify it, but we're happy to share it.
Okay, and then there's another question about topic. A couple of questions. They've previously attended it. One said they attended last April. One said they attended 4 years ago. Should they re-attend to learn the new tools and taxonomy? Seems to be the common question.
So, of course, I'm going to say yes, because as the topic chair, I just think it's a great course. So I am biased in that way. There we go. And I always felt that when I worked at my level 3 center and I was trying to learn this, every time I take one of these courses, I learn more. For somebody who just took it last April, we have talked about possibly creating an update program. So if you've taken in the last 1 or 2 years, that we'll have something online that can give you an update. I can tell you the topic course itself, when the Orange Book came out last fall, we completely redid the book. Again, still kept primary, secondary. PI is still PI, but it did have a major overhaul, and there's been quite a bit of changes. The taxonomy is woven throughout it. Again, trying to have common language, institutional QI, and trauma QI.
Okay. There are a couple questions about workflow and an example. If you have an example to use the trends of the taxonomy classification to address a specific problem.
Well, again, I think I would say if I'm having, you go back to the example of the trauma surgeons and the time, they're not getting to the trauma bay and it's always at a shift change. So perhaps when there's handoff times or whatever, that you make some decision in how you're going, who's going to cover that trauma pager at the shift change time, or when it's coming down, somebody is coming to relieve that. So I'm not sure when they say workflow, I'm sure if that's implementing the taxonomy at their place or, again, for a problem. It's, again, you're drilling down to what the issue is and more precisely of when, where, who, and from that can have a more specific corrective action plan rather than having something broad, rather than just saying, well, you have to show up, you have to be there.
But what I can tell you is that I know that what Jory and her team are doing today is they've got this software built in, and as their trauma nurse specialists go around the hospital doing their thing throughout the course of the day, if they're entering anything into the registry about the patient, it will include performance improvement related issues in near real time using the taxonomy and the drop downs and such that were demonstrated during the webinar.
And that's, I think, is available to everybody in Texas. That was something that they developed through their system. So I think, Kim, we're probably just about out of time. If I could, you know, our hope is that you're feeling a little better about this, maybe just hearing that, oh, shoot, or, you know, oh, phew, I don't have to read about it with the Orange Book. I hope people will take some things more out of this than just what the Orange Book, again, is providing. I can say, that, again, I'll be perfectly honest, the first time I heard about this, I was like, there goes that Don Jenkins, you know, thinking big again. Everything's got to be big, big, big. But, you know, honestly, the more you do this and you can drill and see where these issues are happening, this taxonomy is really going to become your friend. It's not the ACS messing with us. It's, you know, even though it has tax in it, it's not a bad word. And I think you'll see some benefits. It's just, again, it's change and it's different and it's comprehensive. I acknowledge that, but you really are, will see some good things that could happen with that. So with that, if we could please ask everybody to vote with your polling.
I've had it open for a few seconds for those that had it open on your screen. Some people have already voted. I'll give you a few more seconds to vote. And again, I just want to take this minute while we're waiting for a few votes that you will be receiving an email probably in about an hour or two to complete the evaluation. I ask that you try to do that in the next 5 or 6 business days. We'll then process CE certificates and we'll be emailing those to you in 5 to 10 business days, so you should have those by the middle of March. We will be posting a recording of this session online on the online education page of STN along with previous webinars. And Carol and I will talk to see what resources will be helpful. We'll get those posted to the STN online community for all our members. And if you have any specific questions, feel free to email headquarters and we'll get that either to Dr. Jenkins or Carol to try to get any questions that we didn't get to today answered for you. So Carol, it seems okay. You have 34% that feel excited, 34% that feel pensive, 28% are happy, and only 3% are leaving here today depressed.
Okay, that's good. Thank you, everybody, so much for joining us. We really appreciate you taking time out of the day to listen to us.